Hello everyone, my name is Aneka and I'm from India. I'll be speaking about the role of allied health personnel in a palliative care team. My background is in social work and I'm currently pursuing a PhD on the same subject. I'm also one of the founder trustees of Golden Butterflies Children's Palliative Care Foundation, a not-for-profit organization based in Chennai, South India. Let's think about our individual patient at the center. You may be familiar with the concept of total pain, first introduced by Dame Cicely Saunders in 1964. It speaks about 4 domains in which an individual patient may have pain or serious health-related suffering. Physical. These could be symptoms caused by the illness itself or undesirable side effects of the treatment being given to mitigate the illness. Psychological or emotional pain caused due to fear of the unexpected or death, a feeling of helplessness as the illness worsens, and grief. You may be aware of the stages of grief proposed by Elizabeth Kubler-Ross, like denial, anger, bargaining, and depression before final acceptance. Social pain, where the dying patient faces anxiety about his or her own future as well as the future of dependents, the loss of family role, and inability to keep up with social relations and friends, the inability to contribute productively or financially, like keeping a job or doing household activities, as well as spiritual pain, asking existential questions like, why did this disease happen to me? Is it a punishment for some past sins? But let us also remember that this individual patient does not live in isolation, but is surrounded by multiple ecosystems. The individual patient lies at the center and could be of any age, have any life-threatening or life-limiting condition, or be at any stage of illness. This person is surrounded by a microsystem, including their first-line carers, who could be family, extended relatives, friends, neighbors, even peers from their school or workplace. The mesosystem comprises the multidisciplinary palliative healthcare team, which has a doctor, nurse, counselor, social worker, psychologist, and/or trained volunteer, the larger healthcare system of medical specialties like geriatrics, neurology, nephrology, respiratory, cardiac, as well as allied fields like pharmacy, ambulance services, and lab technicians, and other service providers like NGOs, CBOs, volunteer groups, welfare agencies, faith-based organizations, and humanitarian aid organizations. The exosystem consists of support services like the media and police, as well as cross-cutting fields of academia and research. The macro system features policymakers like ministers and bureaucrats, law and judiciary, insurance companies, funders and philanthropies, as well as the culture, belief, and customs prevalent in society. With this background, you can easily guess the many social determinants influencing good or ill health as well as health-seeking behavior of an individual patient. Access to good quality health care. This also involves public infrastructure like good roadways and public transport facilities. People may not want to come to a clinic early enough if they have to spend 10 hours one way using 3 different modes of transport to get to a health facility. Educational level of the family and patient determines how much they value good nutrition and hygiene required to maintain good health. Their economic condition determines if they can afford the treatment offered to them, especially if it must be paid for out of pocket. Social, cultural, even religious context that they live in can dictate whether they have freedom to even access a health facility. Lastly, their surroundings impact if they can maintain their health or are likely to fall ill again. By now, I hope I have convinced you that addressing the various challenges in a patient's life is actually far beyond the scope of any one individual clinician. This is even more so in palliative care, where we deal with difficult situations like intractable symptoms, poor prognosis, terminal illness, end of life, death, and bereavement. At the very basic, the multidisciplinary palliative care team must comprise of a doctor, nurse, social worker or clinical psychologist, and trained volunteer, all of whom have undergone some training in palliative care. If possible, the team can also have a grief counselor who can deal with issues of bereavement, a physiotherapist for patients with limited mobility, a nutritionist or dietitian, and a speech-language pathologist for patients with difficulty communicating. I'd now like to speak about the specific role and tasks that a social worker or trained volunteer can take up as part of the multidisciplinary palliative care team. A considerable amount of our time is spent in counseling. This includes active listening to the patient, their family, their caregivers, and any significant others. We listen attentively to the speaker, paraphrase what has been said, and we're always looking out for any non-verbal cues. We're not there to give out advice to the patient or family, but to help them understand and arrive at what is most important to them in these last days. All the while, we carry a non-judgmental attitude throughout all our conversations. Breaking bad news is best done by the treating physician or at least a palliative care physician. However, sometimes this also is left up to the counselor, possibly because the patient and or family has not understood some of the technical terms used by physician. Collusion is another aspect we deal with in counseling. In a society like in India, collective decision making by the family takes priority, and the patient is left uninformed about their illness, prognosis, or terminal status. During this time, we help the families understand why it is important to inform the patient about his or her last days so that they can go about making their own wishes come true. Social workers or psychologists or counselors also serve as a liaison between the patient, caregiver, and family with the treating or clinical team at a hospital. Often, our patients are not educated enough or confident enough to speak to a medical personnel. We also assist our clients in fulfilling their last wishes, making amends with people, saying goodbye to significant persons in their lives, and fulfilling any last obligations that they may have towards their family. Counseling can be done of an individual, for example, a patient or their relative or their caregiver, or of a family as a whole, or of groups, for example, groups of parents or caregivers. Counseling can also take place in a variety of locations. Within the hospital, in the wards, by the patient's bedside, or in a separate counseling room if the patient is able to walk down. It can also take place at a short stay facility or hospice, at the residence of the patient, or as part of community care services. Compassion is about translating empathy into action. Social workers can provide a variety of practical assistance to patients and their families in their time of need. In India, for example, the central and state governments have various schemes allowing concessions to different types of patients or approaching non-governmental organizations in order to provide assistive devices and equipments like wheelchairs, stretchers, oxygen cylinders, diapers, etc. to our patients. Or if a family is from out of town and needs to set up a home in the city where the patient is undergoing treatment, volunteers can round up all the basic items required for that family to stay independently. Social workers and volunteers can help put together the means to provide for patients and families from low socioeconomic backgrounds. During the lockdown brought about by the pandemic, the financial situation of out-of-station and daily wage earning families was precarious, as the absence of basic nutrition and hygiene would threaten the safety of already immunocompromised patients. Families were supported in the form of monthly groceries and hygiene kits. Similarly, the strict lockdown made access to transportation to reach scheduled treatment appointments extremely difficult and expensive, since adhering to prescribed time schedules for treatment is critical. Patients and families were supported for transportation from their place of residence to the respective hospital for treatment and back. We highly recommend art and recreational therapy for all patients, adults and children alike, as it gives a non-verbal outlet for difficult emotions in stressful times. Prior to the pandemic, we used to host sessions in groups for children as they waited their regular scheduled appointments in hospitals. This benefited both the child as well as the caregiver, as the caregivers could either participate or have a stress-free break. All activities were conducted age appropriately, and the children left with a goodie bag and smile on their face. While we love being able to play with child patients in groups, we also have bedside activities for those with limited mobility. All these activities are carried out by a trained art therapist, supported by an army of volunteers. The pandemic and the inability to meet up with child patients did not stop us. We created magic envelopes. These were eagerly awaited A4 size envelopes which contained some craft activity along with all the required raw materials and pictorial instruction sheet, coloring sheets, a tiny gift, and a snack. Our volunteers curated these magic envelopes every month and created new ideas that would be the flavor of the month. We found that these magic envelopes actually promoted creative talents of the child patients and fostered bonding between them and their siblings. Parents would take pride in sending photos of their child with the completed activity. While our child patients have fun with a range of activities like puppetry, storytelling, pottery making, and fun with colors and clay, we do not forget that they are missing out on their school education. And therefore, our volunteers take bridge classes so that child patients do not fall behind in their studies. Children are engaged in age-appropriate lessons or activities, even in hospital wards. Similarly, their parents or caregivers have usually left their jobs in order to care for the patient and are unable to make ends meet. We find out what the patient's parents are most skilled at and create vocational opportunities so that they can earn a livelihood and support their family and their patient's treatment. Caring for caregivers is essential to promote coping skills and prevent burnout. We conduct group activities for parents or caregivers, which are led by a social worker and supported by trained volunteers. The social worker conducts the program, a didactic lecture on the topic of the day, stress buster activities, and facilitates discussions and interactions in the group, all the while following an individualized approach to each caregiver. While the trained volunteers encourage silent caregivers to speak up and get involved, tackle language barriers, conduct parallel art and recreational activities with children, and manage logistics of sanitation and refreshments. Other activities that a social worker or trained volunteer can do include providing respite to caregivers. Accompany the patient while the caregiver runs some important errands, or do chores around the house and do the outdoor errands on behalf of the caregivers. If appropriately trained, engage in direct patient care like wound management or prevent pressure sores. Sometimes all that is required is just to be present. Caregivers are in dire need of emotional support. Without stigmatizing, encourage neighbors, local leaders, and general practitioners to get involved in patient care and promote the concept of palliative care in society by fighting against social stigma attached to certain diseases. I hope that some of these examples have triggered your own imaginations about what can be done to help patients and families in your own context. Remember, working with others makes us much more than we could ever become alone. Thank you.